All right, so it's 8 o'clock. Hopefully everyone that's going to be here is here, or they'll just show up and catch our chat. As you hopefully know, I'm Dr. Conley. I'm Eric Conley to my colleagues. Eric is fine. I'm going to bring something new to you. Hopefully it's really exciting actually for our profession and for our patients. And so the title is it's Medical Food Formula for the Coma in Glaucoma. And that's important, the coma part, because it is a continuum. Glaucoma is not simply vision is here today and lost tomorrow. It is a slow, insidious process. And so we really want to make sure that we use anything and everything that we can to combat glaucoma. So medical food is important because it's going to give us some options to fulfill what the NIH is looking for us as providers to do. They just announced a new strategic plan that focuses on something called precision nutrition. And it's basically a 10-year plan to invest significant dollars, over $2 billion a year. And their goal is for us as physicians to be able to recommend what, when, why, and how each individual should eat to optimize their health. And that's a different role for us. We've kind of been more of see what walks through the door and deal with it and move on. And we triage if we need to and send it to someone else. But generally, we handle what's here, and we generally get a sense of what their lifestyle is and some of their lifestyle choices as it comes to food and exercise, smoking. But to start getting into specific precision nutrition is new. And so medical food prescribing is important because it gives us an avenue for fulfilling the nutritional needs for patients' pathologies. And medical food is different than, say, a supplement. It's certainly different than just food in general, where you think of, well, we should have vitamin C in our orange juice. It's a very narrowly constrained definition for medical food. And they have to have intended designation to meet a requirement of a disease that is sort of missing. And so we're going to talk about that tonight as we go forward. The other part that's important is if we put a patient on medical food, they have to see us continuously to make sure that they are hopefully improving or maintaining the status that we want and taking the medical food as directed. We use doctor authorization codes, they're called DACs, to make the medical food available to our patient, and Guardian and others can talk to you about that if you're interested. The medical food is formulated, it's processed to fulfill that need as compared to just being available in the natural state. So almost as regulated as medications, but just not a medication that you would prescribe. The harsh reality of glaucoma, as most of you know if you've been practicing, is that a patient can come in and maybe 62 years old, they're coming in for a 4 to 6 month glaucoma check, they're on some medication, you're going to do some testing, and you want to know, are they tolerating the eye drops? They say, great, no problem, no dryness, no irritation. So we're excited. We set target pressures, and we want to know, is the pressure below target? And we find the numbers are great. We do maybe a visual field or an OCT, and we find no significant changes. Things are stable. So we're like, this is great. This glaucoma stuff is pretty easy, and we see the patient back in another 4 to 6 months. The problem is that the patients don't stay stable. And I would argue that eventually all patients with glaucoma progress, and most of them quite seriously if they live long enough. There are certainly exceptions for patients who have very mild glaucoma, but patients are living longer. And so if we were in a lecture hall, I'd show you a hallmark case on the screen, patient showing up in 2013, very mild glaucoma field loss. And you look at 2014 and 15 and 16, and things are looking great. But eventually that field, for several reasons, will start to show evidence of progression. As the nerve morphs from the disease. And so the problem becomes that if it's going to progress and we are treating the patients, then we have to keep ramping up the drugs. We have to keep giving them more and more. And so the problem is that once we exhaust the medications or we find reactivity that's not pleasurable for the patient, then we have to start looking at doing surgeries or lasers and other things. So you might say, well, doctor, you know, that's an N of one, and I have many, many patients who do just fine. But I would argue that there are thousands of cases in extremely well-done studies, and they're the ones we use as professionals. So the early manifest glaucoma trial, it looked at patients who were treated, and we found that if you had treatment, then your progression was maybe 40% as compared to the control group, which certainly had almost a 70 or 80% progression rate. So yes, we treat patients, but that study showed us that even the patients who were getting treatment were getting worse. The ocular hypertension study, which presumably had patients who did not have glaucoma yet, but had risk factors, there was 1,636 patients in that study. And when we looked at the observation group that did not get treatment, they got worse. But the medication group also got worse. And so we saw the same thing over time with the 20-year data that came out from OATS 3. And that really showed us that nearly 30% of all the ocular hypertension patients developed glaucoma by the 20-year analysis. And we also know that 92% of all the enrollees were treated to 20% or more. So they were doing everything they can do to lower pressure, and yet they were progressing. We saw it in the normal tension glaucoma study. So even if you're on a patient with high pressures, 40% did decently with, 20% did okay with treatment. And we saw that, 20% is still progressing. So we're not getting the job done is really the bottom line. And the glaucoma management that we do has been the same for the past 30 years. We identify where we are in the course of the disease. We start treatment with this 25, 30% production, IOP reduction with like a prostaglandin. And then we react to the disease as it worsens with additional medicines and surgeries, and we hope that the progression stops. The problem with this approach is that they do get worse. In our patients, in our practice, we're a glaucoma surgical practice. I have 0 patients that don't progress. I have several patients who are NLP in both eyes, and many, many, many that are hand motion and light perception. And when you see the end result of this disease, there's something to be said for doing something new. And so I want to talk to you about something new that we can do. And so Glaucocetin is a medical food that really has not only exceptional neuroprotection at the retina and retinal ganglion cells, but it's really designed to help patients who have either already established glaucoma or perhaps have risk factors for glaucoma. So we want to really do an add-on treatment to what you're already doing. We want that aggressive pressure reduction, but you really need to think about adding this anti-inflammatory, antioxidant superfood to your treatment protocols. Again, even if a patient doesn't have glaucoma yet, there's a place for this medical food. So I'm excited to bring this treatment option to our patients, and you should be too. The reason it seems to be so effective is that we're learning more and more as the knowledge comes out about glaucoma, and mitochondrial dysfunction is one of the big players. The research is continuing at major eye centers like Wills Eye and sites around the world. And we're looking at the specialties pointing to the same mitochondrial dysfunction as the causal point in many disease states. And so when you think about Parkinson's and Alzheimer's and Huntington's, and certainly in other conditions that we deal with like MS, these are all related to mitochondrial dysfunction. And the problem is that this mitochondria, if you remember, it's a core unit of the cell. It's the power plant, it's the battery pack. And so when it is not functioning, the cell is weakened and gets into this sort of coma state of glaucoma where the cell is on its sort of death cycle. It's heading towards a very dysfunctional place. And we see inflammation rise within the cell. We have cell death eventually. But the reactive oxygen species that develop within the cell are really the problem because they're causing the cell to not function at its normal and not produce ATP or energy that we want. Oxidative stress in the cell comes from many things. We have our genetics to deal with. We have the stress of life that we're all going through now with COVID. We smoke or drink. Those things are not really great for oxidative states in the body. But our environment, which we cannot control completely, exercise, medications we take, and of course our diet, they're all going to lead to issues with mitochondrial dysfunction. And that has impacts on things like diabetic retinopathy, macular degeneration, and of course glaucoma. So one of the things that's important is to realize that the density of mitochondria in the optic nerve and the ganglion cell complex is among the highest anywhere in the body. It's a very high energy, high oxidative stress system. And so we think about of the 90% of the oxygen we're bringing in, we're getting that necessary to use in the mitochondria to make ATP or energy for the cell. And so what happens is when you're producing all this energy, you're also generating what we call reactive oxygen species. And those are sort of the free radical things that can damage within the cell. These antioxidants that we need, we like to have more in the body circulating in the retina and the ciliary body. But not only are they sometimes scarce, but if our diet is missing some of these nutritional issues, then we're really in a difficult state. I presented a case recently about patients who have toxic optic neuropathy, for example. And so again, if they're not getting nutrition, it's basically going to compound things, and that's where optic neuropathy and toxic optic neuropathy come from. But the retina and the optic nerve are among the highest consumer of oxygen per tissue weight in the human body. So it's a high energy place, lots going on. The local inflammation, there's reactive oxygen species, and the cell death eventually is going to be a problem for us in glaucoma and other eye diseases, as well as systemic disease. There's also an issue with microvascular dysfunction. So you get ischemia localized. I've always said that glaucoma is a vascular disease. And so when you have issues with the localized inflammation and neovascular VEGF type factors being produced in the cell, we're going to ultimately lose cell death. Rob Rich, phenomenal physician, glaucoma specialist in New York, started looking at this mitochondrial dysfunction some time ago and tried to look at things that we could do to overcome the retinal ganglion cell death, the neuronal death that happens in even other neurodegenerative disorders. And so we've come up with some formulations to really work to help the mitochondria not only thrive, but sometimes rebound when it's in that coma state, that glaucoma state of dysfunction. And I see it all the time with patients who have really advanced glaucoma. You'll probably see it too. Sometimes they'll come in and say, oh, my vision hasn't been as good, or things are dimmer. It's more that contrast sensitivity. And then next time the eye is doing a little better, maybe the pressure's under better control, they'll tell you, I'm seeing a little better this time. And so there's a lot of fluctuation in glaucoma as you get to the later stages. But that oxidative stress is really the key contributor in the pathogenesis of glaucoma. And those mitochondria are a central source of the target of that oxidative stress. So if we can find antioxidants and anti-inflammatory product, we really can do a lot to help the patients by getting rid of these reactive oxygen species and kind of trapping them down and keeping the ganglion cell healthy. And the evidence is continuing to grow more and more. We have sort of this cycle where the nerve and the ganglion cell gets injured, goes into the state where it's not doing well, but it can kind of recover, and then it's injured again, and then it's recovering. But eventually you can get enough of an injury or a sustained injury, and the cell eventually dies. And then we see a retinal nerve fiber layer dropout on our OCTs or our scans or our GDXs or anything else we're still using. So glaucocetin is derived